Dr. Bussard. Really, to us, she's Dr. Brooke. We are pleased you're back to talk with us today. Your presentation with the question and answer session for Debbie Zimmerman's Food for Life class was so well received. So thank you for doing that. And for our viewers on YouTube for this video, if you weren't present in that session, it was taped. So you can find the link to it in the show notes. And it's on Debbie's YouTube page, the Phyto-fit YouTube channel for you to view. Isn't that right, Deb?
Yes, it is.
Okay, so we are set. In fact, Debbie's here with us today because she's going to help us ask some questions because our focus today is a little bit different. You helped us understand more about your book, Outsmarting Menopause, and what happens during menopause as our hormones fluctuate. But today, we want to take that second piece that you focus on, and that is what happens to our bodies when those hormones, when estrogen's not there. In fact, you taught us that estrogen does more than help us create life in our childbearing years. In fact, I heard you say that estrogen is in every cell in our body. There's a receptor there for estrogen. And so in our 50s and 60s and 70s and 80s and beyond, we're not going to have it. And so what's happening to those receptors? So is it okay, Dr. Brooke, if you talk with us about that today?
Absolutely. It'll be my pleasure.
Okay. And also we want to hear a little bit about men.
Yes, I was going to say that because men have issues as well. It's not just us women. So I think we need to target them too.
Okay, we're all in agreement. All right, so to get us started, Dr. Brooke, would you please tell us about your journey? You know, how you started with education and your career and careers and your health journey. How did that bring you to this point where you're focusing on menopause and beyond?
Well, I think throughout my journey, I have focused on the medicine part originally while I was in med school. Um, I also focused on the fitness piece of it as back in the early 2000s, everyone was saying that the reason that we were having all of these chronic diseases was because of obesity. So I focused more and more on the fitness piece of it and thought, I can really try to help get people moving. And then I saw that that wasn't really working. And I myself started having health issues and I dove into the nutrition piece. And that's when my world exploded as far as there is so much information about how what we put in our mouth on a daily basis affects our health really, as much or more than anything else that we do. So when I got to menopause, I was working, with my own clients who were also approaching the same age. And I realized that these lifestyle pieces all fit together and were so important to help us get through menopause, but also set us up for all those postmenopausal years where we really want to optimize the life that we have for many, many decades ahead. And so I think it was just sort of an intersection of all of these different pieces that I was training in. They came together perfectly to talk about this stage of life and beyond.
Mhm. Well, I can't think of anybody more qualified to talk with us. Somebody who's been through it and studied it and worked with people on this too as well. So thank you for sharing that. Now, I think most women know that heart disease risk increase after menopause. I mean, it is the number one killer of women. So, but I don't think we understand why and exactly what goes wrong. So can you shed light on that? And then if there's something we can do, will you tell us?
Absolutely. So, like you said, cardiovascular disease is the number one cause of death for women and men. But a lot of people they think about aging women and they think about breast cancer
Mhm.
and they don't think about heart disease. So it's so important to put that at the forefront because it's something that we can take measures to try to mitigate our risk. And so, like you talked about in the introduction, we have estrogen receptors all over our body, and that includes in our blood vessels. And when estrogen binds to the receptors in the endothelial cells that line the blood vessels, it allows them to release chemicals like nitric oxide. And you might know that as nitroglycerin. When people take nitroglycerin pills, if they have angina, if they get chest pain, they'll take nitroglycerin because it breaks down into nitric oxide, which is a chemical that sends a message to the blood vessels that they need to dilate and let more blood flow through the vessel. When estrogen binds to those receptors, it also reduces inflammation. And inflammation is one of the underlying drivers of cardiovascular disease. So those two things alone, there's a lot more that estrogen does, but those two are big, big markers for cardiovascular health, whether or not our blood vessels can release nitric oxide and whether or not we can keep inflammation low. So things that that we can do to look at our risk after we go through menopause and we're in the decades of life in our postmenopausal years, we can look at our lipid panels, checking our LDL cholesterol, our triglycerides, of course, checking our blood pressure, knowing what our blood pressure is. And I always recommend people have a cuff at home because we know that blood pressure increases after menopause. It also just increases with aging. Things get stiffer and tighter, and the blood vessels don't relax as much. So taking your blood pressure at home when you're relaxed in a seated position with your bladder empty, not when you're rushing into the doctor's office and you're nervous about talking to them about something and they take it really fast. It's better to do it at home and know your numbers. Other things we can be looking at are our blood glucose and our hemoglobin A1C. Because as women go through menopause, we become less sensitive to insulin, meaning we're more insulin resistant, which increases our risk of chronic diseases, including type 2 diabetes. So if we have extra blood glucose, it attaches to our red blood cells. So in the red blood cell, there's hemoglobin, and that's where the sugar binds. So glucose is sugar. And when you go to the lab, you get something called your hemoglobin A1C checked. And what happens is that the sugar attaches to the hemoglobin. If there's too much, that hemoglobin A1C gets up into the range of prediabetes or diabetes. And why that's harmful to blood vessels is because these little dots, they're actually quite spiky. And it's like walking through tall grass when there's burrs. The burrs will scrape you, right? And they'll stick to your clothes or your socks. And that's how these glucose molecules are when they're on these red blood cells. And so that can scrape the lining of the blood vessel and injure it. And then that causes inflammation. White blood cells come to heal the area, and you can start to develop, the beginnings of plaque. And if you have cholesterol around, that gets incorporated into the plaque. So people who have diabetes, they're one of the main reasons why their health declines is from cardiovascular disease because of this mechanism.
Wow.
So I will. So actually, I'll leave my slides up because I did want to also talk about, I think in part of your question, I was thinking that it's important for us to realize that as we go through menopause, there's certain clues to let us know that we might be at higher risk of cardiovascular disease.
Okay.
And that we found out from the SWAN study. So have you heard of the SWAN study?
I've heard you talk about it briefly in one other podcast. Yeah.
Okay. So this is the study of women's health across the nation. And this began in 1994 at 7 research centers across the US with the goal of just understanding the changes that occur in women during the transition. And in the study, they found that up to 80% of women have hot flashes. They can last 7 years or more. And about 10% of women will have more than 7 hot flashes a day. And of course, this affects quality of life, because of sleep and mood and energy and appetite. All these things get disrupted. But so often those symptoms are thought of just as a nuisance, right? But Swan actually uncovered something really interesting. They took a subset of those patients who were in the study, and they had this smaller study called the Swan Heart Study. And they showed that women who were having these hot flashes were at greater risk for underlying cardiovascular disease. So they looked at 2 markers of cardiovascular health. They looked at how well blood flows after blood vessels dilate. So what they did is they inflated a blood pressure cuff on the arm to restrict blood flow. Then they let the cuff deflate and saw how well did the blood vessel dilate, how well did the diameter of the vessel get wider by ultrasound. So they looked at that, and they also looked at the aorta to see how much calcification was in the aorta. And they found that women who had more hot flashes had these 2 extra markers of cardiovascular risk. So it was a really eye-opening study to say we need to pay attention if somebody has a lot of hot flashes or has had a history of a lot of hot flashes, that we need to dig into it a little bit deeper. And they discovered some key risk factors for the women who were having those hot flashes. Lack of physical activity and smoking, 2 things that we know are related to cardiovascular disease. So,
well, that was one of the other things I was thinking about that you asked, you were asking another podcast about, that this might be the canary in the coal mine for women, just like ED is the canary in the coal mine for men. Wow, that's amazing.
yeah.
And I want to be sure I understand. Can you help me with, you said that when we go through menopause, we're not as receptive to glucose. Is that
To insulin.
to insulin? Excuse me, to insulin. So that means that we don't open the cell and let the glucose in.
Correct.
We should, and so it ends up staying on the bloodstream. Is that correct?
Yes, absolutely. You got it.
Okay.
Yeah.
Okay.
So that is the definition of insulin resistance, just as you stated it.
Okay. All right. So what about bones and muscles? That's a biggie. I mean, we're all worried about osteoporosis. We're worried about scarpopenia now. That was the new thing about losing muscles. Is that because of loss of estrogen?
Oh, yeah. So I know I've got some more slides for you, but let me, I'll talk briefly we'll talk about bone first, and then we can talk about muscle.
Okay.
So bones have estrogen receptors, just like all these other tissues that we're talking about. And bones have certain cells that build bone and certain cells that break down the bone, because it's important that bone continually is remodeling itself. So we get a new skeleton, I think it's about every 12 years, our bones have turned over sufficiently that essentially we have a brand new skeleton. So the osteoblasts are our bone building cells, and the osteoclasts are the ones that chew up old bone and get rid of it so that we don't have sort of these weak spots in the bone. And what happens is when we no longer make estrogen, there's an imbalance of those 2. So estrogen kept those 2 systems in check, and with no estrogen around, the osteoclasts far outpace the osteoblasts. So you're chewing and chewing and chewing up this bone, and women can lose up to 20% of their bone mass during the menopause transition, which is huge. It's an enormous amount of bone to lose. And it's crazy that most women don't get a DEXA scan until they're 65. That's what the recommendation is. But you go through menopause way before that. So anyone who has a family history of osteoporosis, who has lost height, who has had a break that didn't seem like it should have, like it wasn't like you were hit by a car, but you just fell and you broke, something significant. There's a lot of reasons why you can get approval to get a DEXA scan ahead of that 65-year-old mark.
Okay. Okay, that's good.
So I'm going to digress and go to men. So what does that how does men, and this may not be the time to ask that, but how do they lose bone mass when they're going through this, since we're on this topic?
So men and women lose bone just as we age.
Okay.
And so it's 0.5% of our bone mass is lost every year after probably the age of 30, if we're not doing something to try to maintain it. But I don't think you could ever finish, life if you made it all the way to 80 or 90 with the same amount of bone you had at the age of 30. The aging process will just do its thing. But so we're just trying to slow it down. So men and women are losing about 0.5% of bone mass per year, once we reach our peak, which is usually around 25 or 30. But because of this estrogen situation, we go, off a cliff around the time of menopause. But for men, it just stays pretty steady throughout, unless they are in, a situation where they're taking a medication that causes more bone loss, less bone rebuilding. But from a hormonal standpoint, they're really not having an aggressive bone loss because their testosterone is starting to go down.
Okay.
Because their testosterone really, it doesn't usually go down below normal, except in, 10, maybe 20% of men eventually reach a level that's below normal. And we can talk, you want me to dive more into men and their hormones?
No, we'll talk about that.
Okay.
I was just wondering how that, how men played in the osteopenia or osteoporosis.
Yeah. And maybe you could talk about men and muscles, because that's a really big thing. I mean, tell us about women and muscles and men and muscles, because that's scary.
Yeah. So, okay. So again, estrogen receptors are on our muscle cells, and they help, when estrogen binds to those receptors, it helps stimulate what are called satellite cells in the muscle so that they will multiply and build new muscle. And that's great. Love that. Testosterone does the same thing. And, men retain a lot more testosterone through the lifespan than we retain of estrogen through our lifespan. So men do see a decline. I mean, we see it, like sarcopenia is a real thing. Like, we see a loss of muscle mass as we age. Part of that, a major part of that is just due to anabolic resistance. So the body's ability to build new muscle, it's just more challenging. And so we need a bigger stimulus than we did before. So it used to be that, we could, just go about our day. We could do a few push-ups here. We could do a few squats here, and we could build muscle, no problem. Because our body wanted to have that muscle. When we're in our reproductive years, I think it's just our hormones protect us and try to foster this environment that's good for reproduction, for survival of the species. But once we go through menopause and we get into the later years of our life, we're just more resistant to building muscle. So we have to do things like increase our protein consumption. We have to have more amino acids floating around. So when the protein breaks down into those amino acids stimulate certain receptors that say it's time to build muscle. And so we need more of that in order to make it happen as we get older. The other thing is that you can't just take protein. You need to actually do something that stimulates the muscle. So you need to get into the weight room and lift weights, or whatever other form of resistance training you like to do. You need to stimulate the muscle and say, hey, I need you to get bigger, stronger. I need you to do this in order to maintain what you had before and not let it just fade away.
So, Brooke, is sarcopenia a disease or a natural part of aging?
Now, I think it's described in different ways. I think you'll hear it a lot, just describing what happens to us as we age. But I think traditionally it was probably more of a diagnosis of loss of muscle mass, from being bedridden or something like that.
Yeah, and that's what I was thinking it was, that, if we were bed bound, or if we had a serious disease, or if we, were in a bad accident and we weren't able to do these things, that was the onset. But as we age, we also see a large decline in muscle mass, from maybe just not moving as much, or going to the gym, or getting the exercise that we need. So that's why I was wondering, is this just a regular part of aging, or is it actually a disease process?
Well, it's so interesting that you bring that up, Debbie, because when researchers are looking at the loss of muscle mass, it appears that it's a little bit of a stepwise process where it might not be that we just have this gradual decline, but rather we have episodes in our life where we're not able to hold on to muscle mass because we had a surgery, or we were taking care of a loved one who was ill, and so we didn't take care of ourselves for a period of time. It appears at these periods of time where our muscle mass, it's going down maybe a little bit, but then we have these little drop offs, and then we come again, and then we drop off like this. And because we have this anabolic resistance and it's harder to build muscle as we age, it's really hard after one of these step offs to get back up. So it's really interesting that you bring that up, because it does appear to have this episodic sort of situation that's happening with age.
Mhm.
Okay.
So when women, we have those drop-offs, what can we do to build at this age, past menopause, what can we do to build muscle back?
We can just do resistance training as often, not as often weekly, but just as often in our lifetime as we can. So I usually recommend women lift 3 times a week for at least 20 to 30 minutes, and lift weights that are heavy enough that they create the stimulus, but also fuel the body around the workout and for the day so that we are building muscle, because you can't be in a calorie deficit and build muscle.
Mhm.
So that's one issue that I see a lot. Women, as they're getting older, they're putting on weight, they're thinking, oh, I need to diet in order to get this weight off. But once you start dieting, you oftentimes lose some muscle mass. You don't just lose fat. When you lose weight, you lose muscle too. So it's this very fine line of, let's build muscle. And then if somebody has weight to lose, okay, let's do some what I call hypertrophy work, where you're just doing a higher rep range. You're telling the muscle, I still want you around, but I'm going to go into a calorie deficit for a short period of time to try to get rid of some extra fat. So you have to play around with these two things in a very thoughtful way in order to keep your body composition, as ideal as possible.
Yeah. And you talked about I guess it was in your book, I read it, about the thyroid and how you should eat. Well, talk a little bit about the thyroid, because that plays into the weight too, doesn't it?
Yeah, so the thyroid, there's a couple of different things that can be happening with thyroid. And interestingly, I was having dinner on Tuesday night with a friend, who had been to her doctor for her annual checkup recently, and her thyroid was a little low. And she's a totally plant-based eater. She's in her mid 50s, and he wanted her to start on a Synthroid, thyroid replacement medicine.
Mhm.
And she is reluctant to take medicines. She wanted to think through the whole issue. And smartly, she realized that she needed more iodine in her diet. She didn't have any salt that had iodine. She wasn't taking a supplement with iodine. Iodine is really critical for the thyroid to make thyroid hormone. And she increased her iodine, and her thyroid level came back up. So when we think about thyroid and usually if you get your thyroid tested, if it's not normal, it's usually low. And then you have to think, why is it low? Is it because my thyroid just can't make thyroid hormone? And if that's the case, is it because, I've got a tumor and my thyroid just needs to be taken out? Like that's a total reason for needing thyroid replacement medicine. But it might be you're missing iodine. It might be that you're eating too many processed foods and added sugars, and you've got an inflammatory process that's going on, and it's causing, too much inflammation in your body, and it's impairing the thyroid's ability to make thyroid hormone. So it could be that there's something about your diet that's causing the issue. One thing that I have seen is people who, again, are dieting and they're eating too little, their body recognizes up in the brain, up in the hypothalamus, recognizes that there aren't enough calories coming in. And as a protective mechanism, the body says, we need to slow things down. And how do we do that? Well, the easiest way is to go right for the thyroid, who's the master of metabolism, and say, I need you to slow down. And so the thyroid level might be low just because somebody's not getting enough calories. So you can say, okay, well, let's increase your calorie intake for a few weeks, retest your thyroid and see if that's what the problem is. So there's a lot of secondary causes of low thyroid that should be investigated. And I think the reason that I bring that up in the book is because there's so many changes in different hormones that interact with each other. Estrogen and thyroid, they talk to each other. Are we safe? Are we good for reproduction? Is this a good environment to carry a baby in? And then when estrogen's gone and the thyroid's like, I don't really have a good, friend to tell me what to do over here. It's getting other messages based on lifestyle issues. And so you just need to dig into all the potential causes and try to figure out the underlying root cause before you just replace the thyroid.
Okay, that's good. And you also mentioned about if you wanted to diet and you were on a whole food plant-based, about the timing of your meals and the calorie intake. I think you said that the breakfast was supposed to be the big meal.
Mm-hmm.
And then lunch was, you're supposed to eat on time. I remember that because your body's expecting it. And if you don't, you go into sleep mode. The thyroid goes into sleep mode. I love that. And then what was it? Lunchtime was a good sized meal too?
Yeah, so I like to think of it as breakfast like a queen, lunch like a princess, and dinner like a pauper.
Okay.
Yeah, so that really fuels your body for the day's activities.
Okay.
It's sort of eating with your circadian rhythm, because when you go to bed at night, your body doesn't need energy in the same way that it does when you wake up in the morning.
Mm-hmm.
And a lot of people, they're like, oh, I'm just not hungry in the morning. Well, it's because you had a huge dinner. So you have to give yourself time to make these shifts in order to get your body to reset and wake up and feel hungry. And Debbie, you'd probably back me up on this because I think you eat dinner really early, right?
Very early, yes. And
And
breakfast very early. Breakfast is usually at 5.
okay, yeah. So
But yeah.
yeah, once the day is done and you're ready to sleep, you don't need to have a lot of food in your digestive system that needs to be taken care of. You'd rather have your body use its resources to, detoxify and, clean out, cells and debris that it wants to get rid of during this time of rest and recovery when you go to bed.
Yeah. Well, I can testify. Debbie gets up and answers emails in the morning.
4 o'clock in the morning, we are answering emails.
But don't bother her after dinner. She's done. She's done her work for the day. Okay, well, now you were getting ready to talk to us about muscles, and I think we got some good stuff on that. But what about tendons and ligaments? That was of interest to me because, I've heard of people, women, getting rotator cuff surgery, and I'm thinking to stabilize muscles and tendons. I'm thinking they're not baseball players and basketball players or frozen shoulder, and then I'm worried about a tendon in my leg. It's not strong enough to keep me from turning my ankle. I know tendons are important and ligaments. Are they related to estrogen loss?
Oh yeah, yeah. So I would say the rotator cuff is one of the most common issues that women have. So have you heard of the musculoskeletal syndrome of menopause?
No, no.
No.
Yeah, so it's been given this name now because estrogen's involved in making collagen. And so collagen is a critical structure that's in our tendons and our ligaments. It's actually the most abundant protein in mammals. It makes up about 25 to 35% of our protein content in our body. Like that's how abundant it is. And once we no longer make estrogen, our collagen decreases. And that's why our skin changes, and our connective tissues change. And so we become, our tendons and our ligaments, they get more stiff, and it increases our risk of injury because these tissues that used to have some elasticity in them, it has declined. So taking care of our connective tissues in other ways becomes really important. So it's important to warm up and cool down before and after exercise, like we didn't do before. We would just jump right into whatever it was and, feel like we were pretty good. But this happens for men too. Men need more time to warm up and cool down, and, their collagen levels decrease as well. Again, you can see it just because the skin is a good indication of a lack of collagen. So things that we can do. Well, first I want to say for women who've worn heels over the years, they shorten one of the tendons that is so important, and that's the Achilles tendon. Because when you're up on that heel, the calf muscle gets shorter, which a lot of women love because their calves look so pretty like that, right? But the tendon gets short. And then they enter this phase of life where they're not wearing heels as much, and they're dropping their foot, down flatter to the ground, and that tendon is getting more of a stretch on it. So I would just say anybody who wears heels, take as good of care as you can of the Achilles tendon, and try to not stay in the heels when you don't need to. But things we can do, we can use foam rollers, we can use, tennis balls, we can use, massage guns, apply heat to the area. If you apply cold, that's good for like pain relief sometimes, but it just makes things a little stiffer because you have even less blood flow when you cool things off, because it shrinks the blood vessels down. And we want the blood vessels to dilate and bring nutrients into those areas.
Okay.
So, yeah, and then just having a good diet that's anti-inflammatory, that's filled with all of our micronutrients that are important for, trying to maintain those structures in our connective tissue as much as we can. I would say we just need to be really mindful and not do things too rapidly and, without thought.
So Brooke, when you're talking about warm up, Are you
Mhm.
talking about like doing cardio, like getting on the elliptical and getting that blood flowing to all parts of the body? Or are you talking about doing a very light workout with weights before increasing, or both? Just so our audience knows specifically what you're referring to as a warm up.
I love that question, Debbie. That's very specific and granular and appropriate. So I do think, going for a walk, whether it's outside or on a treadmill, at first, that's great to get blood flowing to all the areas. But a lot of times when people are walking, they're not going through all their movement patterns,
Right.
right? They're just in that one movement pattern. So it's important to make sure that we squat and we hinge and we push and we pull and we get all these movements going in all directions so that, you're thinking about, okay, how am I doing with, rotation of the shoulder? How am I doing with protraction and retraction of my shoulder blades? Like, try to get your body moving in all the ways that you feel like you can. One of the things I love to do is a squat to stand. So I feel like it gets a lot of different movement patterns and muscle groups together. So I stand with my hands over my head. I hinge at the hips and touch the ground. Then I squat down into a squat. So now I'm like in a squat, low on the ground. And in that position, you can sort of noodle around and feel your ankles, flexing and extending. You can feel your hips sort of going through all these motions. And then I'll raise my arms to the ceiling while I'm in that squat. And you get all of these back extensors engaged, and then you stand up. That's one really good mobility exercise to do. Another one that I love is the inchworm. Are you guys familiar with the inchworm?
No.
So, so you hinge forward and, take your hands to the ground, bend your knees a little bit if you need to get your hands down, then walk your hands out into a plank position. Now, when you're in that plank position, you're in a straight arm plank. If you've got wrist issues, some people go up on their knuckles, or use a dumbbell so they have something to hold. So I have a lot of older women who I've worked with who have wrist issues and they don't like this position.
Mhm.
But once you're in the straight arm plank, you can bring one foot up to the same side hand. So you're in a runner's lunge,
Mhm.
the runner's lunge,
Right.
and then you can take that arm on the same side and open up, reach that arm to the ceiling so that you're getting a rotation in your thoracic spine.
Right.
Um, and then, do it on the other side, then walk it back. And then while you're walking it forward and back into that plank position and back, you can stop at points and do like a down dog and pedal your feet out if you're tight in the hamstrings or the calves. But yeah, really thinking through all the body parts and the ways that they move, right? Like we know that the shoulders and the hips, those are ball and socket joints. So, those can go through all these ranges of motion. The knee and the ankle, those are hinge joints. All they do is this, So thinking about the body and all of these different movements instead of just walking to get the blood flowing. So like you said, you could do the exercises that you're going to do for the day, but do it with no weight or a little bit of weight
Mhm.
just to warm up that movement pattern. That's great also.
Okay, so question for you, because I talked about the cardio and you just talked about the stretching. So I have always kind of encouraged people to do a little cardio before they do the stretching just to get the blood flowing. But would doing that light stretching that you were just referring to be okay to do without the cardio?
Yes. And
Okay.
the reason is because I'm not having you stay in the stretch for a long period of time. So I'm not there for, 10 seconds, lengthening a tendon and activating the Golgi receptors.
Mhm.
So So if you come in and out of the position in a shorter period of time, you're talking more about mobility than
Mhm.
about flexibility.
Okay.
Yeah, we're not trying to lengthen the muscle in like we would in a post-workout scenario. We're trying to say, hey, I want you to move like this. I want you to, get longer and get shorter and, roll around. And you're in a dynamic movement pattern, not static.
Okay.
Yeah.
When you're getting that blood flowing so it can take nutrients, let's talk a minute about nutrition because that I'm sure that impacts all of this. Like when you were talking about increasing the protein, being sure you have enough protein, how much protein should a postmenopausal woman be ingesting, and what are some of the other nutrients that are important?
Okay, so protein is highly debated, as you know, I'm sure. But it looks like a good recommendation for a postmenopausal woman who is doing resistance training is around 1.2 grams per kilogram of body weight. I think traditionally the recommendation was 0.8 grams per kilogram. So this is about 50% more. So a woman who was targeting 50 grams of protein a day, once she's gotten to this age where she has more anabolic resistance, we're saying take that up to 75 grams
Okay.
a day. Yeah.
And they ought to add to that the weight training. So that's
Yes.
okay.
Yeah.
Okay.
And then it's important to fuel around the workout so that as you go into a workout, it's not good to go into a workout with no fuel on board in what we call a fasted state.
Mhm.
Not very good. The body's like, what's going on? It's stressful for the body, very stressful. And we don't want it to be stressful. We want it to be, oh, here, let's go, work these muscles out and make them stronger. Like we're not trying to, cause distress. So we want to have some carbohydrates on board before we go into the workout, and a little bit of protein. So for me, a lot of days, that is just a soy latte that I make with, I don't drink coffee because I'm one of those postmenopausal women who can't tolerate even decaf without getting a headache. So I use a dandelion blend. So it's dandelion root and some chicory root. And I do that with some soy milk and some cocoa powder and a little bit of maple syrup. And so I make myself this latte that has protein and carbs in it. And then I have good fuel for my workout. And then after my workout, I'll have a bowl of, quinoa and beans and cucumbers and green peppers and that sort of thing. So that allows my body to refuel and to give me circulating amino acids to build muscle in response to the stimulus that I just gave my body.
And a plant-based diet is the best for our bodies after postmenopause too.
I mean, I certainly believe so. I think there's a lot of good, strong evidence that a plant-based diet, really helps reduce our risk of cardiovascular disease, which is the number one thing that, gets us. It reduces our risk of cancer, it reduces our risk of diabetes. It helps us maintain an ideal body weight. So I have not been convinced otherwise at this point.
Okay, good.
Yeah.
All right, so what we talked about the thyroid, the tendon, the ligaments, and one of our members asked, what about kidneys? Everybody I know in my older age group, they have kidney problems, things like that.
Yeah. So the kidneys are, I mean, they are impacted by the loss of estrogen. Again, we have estrogen receptors everywhere, including in the kidneys. And the kidneys are really important for getting rid of toxins, for helping regulate fluid balance during pregnancy, for one thing. They, yeah, I mean, the kidneys are, I mean, they're a life essential organ because if they go wrong, people have to go get dialysis to get the kidneys out or to get the toxins out that the kidneys can't get rid of. So I think it's important to remember that the way the kidneys work is by blood vessels bringing these toxins to the kidneys, and then the blood vessels pair up with, I'm going to actually show you a slide.
Yeah, that'd be good.
Hold on one second. I think this is an important thing that people might not really know or think about. So let me share my screen. Okay. So inside the kidneys, we have nephrons. And the nephron is the unit where the blood gets filtered and the toxins leave through our urine. So blood that is in our body, it's accumulated metabolites from our biological processes. It might also have byproducts of medications that we took that broke down. It might have excess hormones, acids, other, minerals that were in our food. It's going to come in. So the blood's going to come into this glomerulus, this unit, and get filtered by the glomerulus all the way down through these loops of Henle. And then the blood is going to come back out into our veins and go back into our body. And then this collecting duct takes those toxins and dumps it into our urine. So you can see that the blood vessels are critical for this whole process. So this goes back to what we talked about in the very beginning, is that the estrogen receptors are on these blood vessels, allowing them to dilate, allowing them to not be inflamed. Because a lot of times what happens when people get chronic kidney disease is that they get fibrosis and they get scarring in these tissues, and the filtration system no longer works. So it's really important to think about your blood vessels and your cardiovascular health as sort of what is the precursor to your kidney health, because they're intricately tied together.
When we think about menopause, at least I'm thinking about the expanding waistline. And I know visceral fat is one of the issues, but if you have a BMI, 21, 22, but you're still having the waist issue, do you need to be concerned about the visceral fat? Does that make sense?
It does make sense. So yeah, you're asking if you could have a normal BMI, but your visceral fat is more than it should be.
Correct.
Yeah. Okay. And the answer is yes.
And I don't know that, but I'm just saying, because a lot of people are striving for that normal BMI, under 25.
Right.
And now they're in menopause and you're seeing the fat distribution in a different light, more around the waist than the other parts. So,
okay. So I think it's important to realize that our waistline can expand, and it could be visceral or it could be subcutaneous fat. So visceral fat is the fat that is underneath the muscular layer. So we've got our abs, and if we have fat on the outside of our abs, it's subcutaneous fat. It's just in the skin. If it is behind the muscle, it is visceral fat, and it can be wrapping around our organs that are in our belly, whether it's our liver or our pancreas or our spleen or our kidneys. That fat is super dangerous because it's highly inflammatory and it sort of chokes those organs. If it's subcutaneous, if we can grab it easily, or if it's rolling over the top of our pants, not as dangerous, you know? A great way to tell visceral fat is how taut is the belly. Like you can picture somebody who's got a really taut belly that you could like drum on.
Mm-hmm.
That's visceral fat pushing that that muscular layer all the way out to the front, and so it becomes like a drum.
Okay.
But so as we age and go through menopause, we're in our postmenopausal years, and we're thinking, oh, this is so annoying that this, my pants don't fit the way they used to, and I've got this, little bit of roll over the top, and it's driving me crazy. That is because without estrogen, our body no longer thinks of itself as a reproductive machine, in that we don't store fat in the gynoid regions anymore, which are the hips and thighs. So those areas, when women store fat there, that is the lowest risk fat storage.
Mm-hmm.
So now we start to put our fat in the android distribution, which is the same place that men normally put them, right? So what do we call that? The apple shape versus the pear shape.
Mm-hmm.
And that's because we don't have estrogen anymore. So we go from gynoid to android distribution. And then the next step to look at is, once we're in that android distribution, is it subcutaneous or visceral?
Okay.
The subcutaneous is super annoying, but it's not as dangerous. The visceral, more dangerous, and we should make sure we minimize that. The best way to tell how much visceral fat we have is to get a DEXA scan that does body composition, not the DEXA scan you go to just to get your bone mineral density test done, but like a full body DEXA that looks at body composition.
Okay.
And where do they do those?
So at just all over the country in certain areas, you just like Google full body DEXA body composition and see who's offering them. And usually, I've never seen insurance cover it. So it's about $180, but I tell people it's really good information to have to know how much lean mass you have and how much fat mass you have and how much of that fat mass is visceral fat. So for people who I'm working with who are doing or trying to work on their body composition, we just do a DEXA once a year because it takes a long time to change your body composition.
Mm-hmm.
But it can be done, but you don't need to do a DEXA very often. So once a year or once every 2 years, just to sort of see where you are, make sure you're going in the right direction, make sure you're not going in the wrong direction, I think is quite helpful.
Mm-hmm.
Okay, I have one more question.
Okay.
Sorry, Kathy, but one more. And this is one that everybody is thinking about. When is it too late to take estrogen supplements?
Okay, that is very nuanced. Right now, I'm sure you've read the guidelines if you're asking this question, that, if you haven't started them, then it's not recommended to start after the age of 60 or after 10 years post-menopause. If you're already on them, there's plenty of OBGYNs that I've talked to who are taking them to their grave, they said, unless something dreadful happens in the meantime. But yeah, so there's two different scenarios. If you're already on it, how long can you stay on it? It looks like you could probably stay on it forever unless something happens. If you haven't already started it, it would be a very nuanced discussion with a menopause specialist to figure out whether or not you're a good candidate. And ways that they would determine that would be they would look at any cardiovascular risk factors that you have, and any history of any reproductive cancers that you've had or any family history of those things. So there'd be some things they'd want to really dig into before, potentially in a shared decision-making way, say, yes, you could go on hormone replacement.
Okay,
Okay.
good. Good question. I have one more question, and we
Okay.
really appreciate your time. This has been
This is
tremendous.
awesome.
I just felt like I read another book. But this one is someone who did read your book, Outsmarting Menopause. And she got to the section on nutrition and she just got scared because she's whole food plant-based. She and her husband, they're both slim at their proper weight. They both share a love of biking and hiking. He's a businessman, she's a Pilates instructor. And their plates look the same at every meal because she prepares their food and they always eat at home. And their weight has not changed. And she's eating the same number of calories he is. And she's worried, why aren't I gaining weight? Why don't I gain weight? Because he's living on that number of calories at a much taller body frame than mine. So should she be concerned?
No, no, no. So I think I saw this question, didn't I? Is she the Pilates instructor?
Yes, yes.
Yeah. So when we think about energy balance, we look at our total daily energy expenditure in order to figure out how much we can consume and maintain that balance without gaining weight or losing weight.
Mhm.
As a Pilates instructor, I'm going to bet that her total daily energy expenditure is significantly higher than her husband's, or higher enough to make up for the discrepancy in the amount of food that they eat that looks like she should be gaining weight, but actually she's maintaining her weight. So when you look at total daily energy expenditure, you look at basal metabolic rate, then you look at physical activity,
Mhm.
and then you can look at other smaller things that will add into that equation. But that physical activity
Mhm.
piece, it's a big piece,
Mhm.
And for somebody who is an active uh, Pilates instructor versus somebody who's sitting at a desk, there's a pretty big swing there.
Okay. Okay.
Yeah. So I
Yeah.
think that's all it is. Yeah.
Okay. Good. We'll share that with her. Now, I want you to talk about your two newest books and also the one you had before, so that if we want to learn more from you, do you have a website? Tell us about that and we'll put it in the show more.
Okay. Yeah, so I'll just tell you, my website is drbrookebussard.com. And if you go there, you'll see all of the resources that I have created. Outsmarting Menopause, which we've talked about today, and also the fitness journal that I created that goes with Outsmarting Menopause. And the fitness journal, I love it. I feel like it's the perfect amount of strength and hypertrophy work and a little bit of core work. If you want to do the core work, it's totally optional. And then there's some jump training in it for people who are trying to build bone and maintain bone, which should be most of us. But some people, have really good bones and, they sort of get a pass on doing the jump training, as well as doing some high intensity work. So HIIT is high intensity interval training. SIT is a subset of that. It's sprint interval training for shorter periods of time. And those are really good for boosting our brain health, for bringing cortisol levels down, for releasing some testosterone and growth hormone to help build our muscles. So all of that is incorporated into the fitness journal, and the parts of the fitness journal are described by characters in the book. So it all sort of fits together.
Mhm.
My first book was Chew on This, Bite-Sized Stories About Nutrition. And that is just sort of my way of helping people understand about macronutrients and micronutrients and, just the basics of nutrition in a way that, hopefully is fun to read. And let's see, what else was I going to tell you about? I did want to mention I've this coming up in January. I have partnered with Dr. Simone Zarabi, who's a lifestyle medicine physician in Greece. And she went through a very early menopause in her 20s because she had cancer treatment.
Mhm.
And she's lost a lot of bone and muscle mass. And when she read my book in the Fitness Journal, she reached out and said, would you want to do a program with me for women to help them sort of regain, all of the things
Yeah.
that, we need in postmenopause. So she and I have partnered. We're doing a 12-week program that starts on January 12th. And it's called Menopause Makeover .online. That's the website that people can check out if they're interested.
Okay.
And she's a wonderful, wonderful physician and just has a great mindset. And I think we're going to have a lot of fun with the program. So, yeah, I think, those are.
So that one sounds like what you've told us today put into how to on.
Exactly. Yeah.
That's great.
That's
And it was
awesome.
menopause.makeover.com
.online.
.online. Okay.
Yeah. Mm-hmm.
I just thought it was online with .com.
Yeah. Yeah. All the .coms are taken these days,
And before we leave, because gosh, so much to think about that you shared with us. This has just been fantastic. We really appreciate your experience, and your knowledge level is just tremendous. But are there some things that you would like to share with us before we leave? The key points that we can walk away with?
I think it's really important to remember that menopause happens and it's so abrupt, and it sort of creates this intersection with aging. And once we lose that estrogen, all of the chronic diseases that men were actually already starting to experience start to happen to us because we lose that protective effect. So we're about, 10 years behind them as far as heart disease and diabetes and things like that. So I think it's really important to remember that our lifestyle pillars that really reduce our risk of chronic diseases with age are the things we need to lean on. We have to get serious and real about the way we feed ourselves, the way we move, and then all the other really important things that make life fun, like, being with our friends and, surrounding ourselves with like-minded people and, engaging in the world in the way that we want to. And I think as far as the physical activity piece, it's always painful to read it, but I see it over and over again. And that is that we just don't realize how much less we move year after year after year. And we just need to get up and get moving to try to mitigate some of these issues, including that extra roll around the middle. And, I'm not saying that's totally the answer, but it's definitely not going to hurt. And the more we stay active, I think the better outcome we will have.
Great. Fantastic. Thank you so much. We really appreciate it.
Oh, I enjoyed it, Kathy. And Debbie, great to see you as well.
This was awesome. Thank you so, so much.